Imagine this. It's a Tuesday morning. You're groggy. You're in front of the bathroom mirror, just going through the motions. You tilt your head back to gargle, and you see something. A shadow. A bump.
Right.
So you stop, you look closer, you touch your neck. And there it is. A lump. And it moves when you swallow.
It is a moment of absolute cold panic. I mean, that is a universally terrifying feeling.
Oh, absolutely. The C word is just flashing in neon lights in your brain.
Exactly. But here's the thing, and this is what we're really digging into today. For a doctor, that lump isn't just fear. It's the first chapter of a detective story.
A detective story.
A logic puzzle, yeah.
Yeah.
Where the clues aren't in a lab, not at first. They're in your history, your voice, even the way you stick out your tongue.
And to guide us, we're looking at a really fascinating set of clinical notes. It's about a specific patient, a woman named Rohini.
Right.
She's 36, from Mumbai, and she came in with a swelling in the front of her neck.
Rohini is the perfect case study because her story hits almost every major point. And this wasn't something that just appeared. This thing had been slowly, quietly growing for 3 years.
Wow. 3 years is a long time.
It is, but the thyroid is a master of disguise. So our mission today is to walk you through how a surgeon figures out if a lump like Rohini's is a harmless goiter or something much more sinister.
All using deduction, before they even order a scan.
Pretty much.
So let's start with her profile.
Yeah.
Rohini is 36. She's female. Looking at the research, that is absolutely not a coincidence.
Not at all. You walk into any thyroid clinic in the world, look around the waiting room, it's going to be overwhelmingly women. There's a huge gender link here.
I saw the stats, yeah.
Yeah.
But why? Is it just bad luck? Or is there a biological smoking gun?
No, it's biology. And the smoking gun is estrogen. It turns out the thyroid is deeply connected to the reproductive system. The actual cells of the gland, follicular cells, they have estrogen receptors on them.
Wait, really? The thyroid has receptors for sex hormones? I thought it was all about iodine and metabolism.
It cares about a lot more than that. It has these little docking stations, ER alpha and ER beta. When estrogen is in your blood, it binds to them and basically whispers to the cells, proliferate.
It's like a low-grade growth serum.
That's a great way to put it. So just being female with higher and fluctuating estrogen puts you at a higher baseline risk for these nodules.
Which means things like pregnancy must be bonfires.
Exactly. During pregnancy, you have a huge surge in estrogen, plus another hormone, HCG. Both of them heavily stimulate the thyroid. It's actually normal for the thyroid to get bigger during pregnancy.
They call it a physiological goiter, right?
We do. It's gearing up. So you imagine a woman with multiple pregnancies, and Rohini had 2 kids. That stimulation adds up over the years. That history matters.
The notes also mentioned a connection to the immune system.
A massive one. Autoimmune diseases, where the body attacks itself, they love to target the thyroid. Think Hashimoto's or Graves' disease.
And the ratio there is
For Hashimoto's, it's staggering. It's about 9 women for every 1 man.
9 to 1. That's not a gap, that's a canyon.
It is. And the theory is it's linked to the X chromosome. Women have 2, men have 1, and the X chromosome is loaded with genes that regulate immunity.
So women have a stronger immune response.
In a way, yes, more robust, which is great for fighting off infections, but the downside is it's more prone to friendly fire, autoimmunity.
And of course, iodine.
You can't forget iodine. Women need more, especially during lactation. If you're deficient, your thyroid has to physically grow larger just to scavenge it from your blood. So Rohini walking in, the statistical deck was already stacked.
Okay, so that's the why. Now the lump itself. Rohini said it grew over 3 years. Started small, got bigger.
And that timeline is the first big clue. In medicine, speed tells you so much. The notes call her growth insidious.
Insidious usually sounds bad, like a movie villain.
It does, but in this context, it's actually reassuring. It means slow, gradual, benign things tend to be lazy growers. They take their time.
So what's a bad sign?
Acceleration. When a patient says, "Doc, this was a pea last month, now it's a lemon," alarm bells are ringing. That suggests malignant transformation.
What if it's the opposite? What if it happens overnight?
That happens, and it's terrifying for the patient. They think the cancer just exploded.
Yeah.
But interestingly, that's almost never cancer. That's usually a hemorrhage, a bleed into the nodule.
So it's like a plumbing problem, not a malignancy.
Exactly. A little blood vessel bursts, the nodule fills up like a water balloon. It's scary, but not what you think.
So slow is usually okay, fast is bad, instant is usually a bleed.
Usually. But the doctors then ask Rohini a very specific question about her voice. The notes say, no history of change in voice. And that is a pivotal question.
I would have just assumed that's for a sore throat.
It's much more sinister. There's a nerve, the recurrent laryngeal nerve, that runs right behind the thyroid. It controls your vocal cords.
So a big lump just crushes it.
Well, a benign lump will just push it aside. It makes room. But cancer invades. It eats into tissue. If a cancer infiltrates that nerve, it paralyzes the vocal cord on that side.
And the voice changes.
The patient gets a hoarse, breathy voice. So when a patient with a thyroid lump has hoarseness, a surgeon's stomach just drops. It means the lump has likely broken out.
So a normal voice is a very, very good sign. Okay, let's talk metabolism, weight and appetite. This part felt like a riddle.
The classic thyroid paradox. It's how we figure out if you're hyperthyroid, too much hormone, or hypothyroid, too little.
Because normally you eat more, you gain weight.
Right. But with hyperthyroidism, your engine is running red hot, you have a crazy appetite, you're eating everything, but you're losing weight.
We lost despite eating more.
That's the tell. And hypothyroidism is the opposite. The engine's sluggish, you have no appetite, you're skipping meals, but you're still gaining weight.
Sounds incredibly frustrating. And Rohini.
Normal appetite, stable weight, she was euthyroid, her hormone levels were fine, the lump was just a physical thing, not a chemical one.
There was one other part of the history that seemed like a trap, the family connection. They checked for something called MNN syndrome.
Yes. Multiple endocrine neoplasia. This is the check that saves lives on the operating table. It's a genetic syndrome where you get tumors in different glands at the same time.
A package deal.
An unfortunate one. If you have a specific type of thyroid cancer, medullary, you might also have a tumor on your adrenal gland called a pheochromocytoma. Why
does an adrenal tumor matter if you're operating on the neck? They're so far apart.
Because that adrenal tumor is a ticking bomb full of adrenaline. If you don't know it's there and you put the patient under anesthesia, the anesthesia can trigger it to dump all that adrenaline at once.
Massive adrenaline overdose.
A lethal one. Your blood pressure skyrockets. The patient can have a stroke right there on the table.
Wow. So checking family history isn't just paperwork. It's making sure you don't set off a booby trap.
Precisely. You always rule out the pheo before you touch the thyroid.
Okay, let's move to the physical exam. This is where it gets hands-on. First, the doctor just asked Rohini to swallow.
The swallow test.
Yeah.
Classic. You watch the lump as they swallow. If it moves up with the larynx, it's almost certainly thyroid.
Why does it move?
It's tethered. The thyroid is wrapped in something called pretracheal fascia, which is attached to the voice box. When you swallow, your voice box moves up, so the thyroid gets dragged along for the ride.
Okay, so her lump moved. Confirmed. Thyroid. But then they asked her to stick her tongue out, and it didn't move.
This is the tongue test, and it's designed to rule out an imposter.
Imposter.
Yep. As a fetus, your thyroid actually develops at the base of your tongue.
In your mouth.
Way back. Then it migrates down your neck. But sometimes it leaves a little track behind the thyroglosal duct, and a cyst can form on that track.
So if you stick your tongue out,
you're pulling on that track. So if the lump moves with your tongue, it's a cyst. Rohini's didn't move. That confirmed it was a true thyroid nodule, not a developmental cyst.
I love that. Simple mechanics revealing embryology. Okay, one more test that sounded bizarre. Pemberton sign. You have the patient raise both arms.
Reach for the sky. Yep. It sounds silly, but it's checking for a retrosternal goiter one that's growing down into your chest.
Behind the breastbone.
Exactly. Now, the opening at the top of your rib cage, the thoracic inlet, is a very tight space.
Crowded real estate.
Very. And when you lift your arms, you narrow that space even more. If there's a goiter down there, it gets pulled up and acts like a cork in a bottle.
Playing the drain.
You got it. It compresses the big vein draining blood from your head, the superior vena cava.
And the patient, what do they feel?
Their face turns beet red, congested, flushed. They might get dizzy or breathless. That's a positive Pemberton sign. It tells the surgeon this is going to be a tricky operation.
But Rohini's was negative,
Thankfully.
Okay, so we've poked and prodded. Now we need to know what it is. And the notes mention a thyroid paradox. Usually a hard lump is bad, right?
In the breast or prostate, absolutely. Hard, irregular, that's the enemy. But the thyroid breaks the rules.
How so?
A completely benign nodule can feel rock hard, maybe from calcification over years, or just because it's under a lot of tension.
And the other way around.
Conversely, a really nasty cancer can feel soft or mushy because it's grown so fast it's outstripped its blood supply and is dying in the middle. Necrosis.
So you can't trust your finger.
You absolutely cannot. You need more data.
Speaking of confusing things, the notes debunk something called lateral aberrant thyroid, which sounds harmless, just some extra tissue on the side of the neck.
It sounds harmless, but it's a lie. It's an old term. If you find thyroid tissue in a lymph node on the side of the neck, it's not aberrant.
What is it then?
It's metastatic cancer. Papillary thyroid carcinoma that has spread 100% of the time. The horse has already left the barn.
That's a wolf in sheep's clothing. Okay, so now we get high tech, the ultrasound.
Right. Ultrasound is our eyes. We use a scoring system, Thyroids. We look for suspicious features. Is it taller than it is wide? Jagged margins, microcalcifications.
The gold standard is the needle,
Yeah.
the FNAC, fine needle aspiration cytology.
It is the gold standard for many types, yes. Papillary, medullary, but there's a blind spot, a huge one.
Blind spot.
The needle cannot tell the difference between a follicular adenoma, which is benign, and follicular carcinoma, which is cancer.
Wait, really? It can't tell benign from cancer? That seems like a massive flaw.
It's a limitation of biology. Here's the analogy. Imagine a bank lobby. A customer inside is the adenoma. A bank robber inside is the carcinoma.
Okay.
But here's the catch. The robber is wearing the exact same suit as the customer. The individual cells look identical.
So you can't tell them apart.
Not by looking at them. The only difference is behavior. Did they break the door down to get in?
Invasion.
Exactly. To diagnose follicular carcinoma, you have to prove the cells have invaded the capsule around the tumor or invaded blood vessels.
And the needle can't see that.
The needle just sucks out a few guys from the lobby. It doesn't show you the door frame, so you have to remove the entire lump just to look at the edges.
So you have to do surgery just for diagnosis.
Yes. If the needle comes back follicular neoplasm, the surgeon has to say, we don't know. We have to take it out to find out.
Which leads us to the OR. Rohini has a hemithyroidectomy, removing half her thyroid. This anatomy is high stakes.
It's a minefield. You're working in a tiny space packed with vital stuff. We mentioned the recurrent laryngeal nerve.
The voice nerves.
Cut that, the patient wakes up hoarse forever. Cut both, and it's an airway emergency.
But there's another nerve, the external branch of the superior laryngeal nerve.
Ah, the singer's nerve. It's sneaky. It controls the muscle that creates high-pitched sounds.
You can still talk if it's damaged.
You can, in a normal tone, but you lose your upper range. You can't project. If you're a singer, your career is over. Even just yelling across a park becomes impossible.
Wow. And then there's the calcium, the parathyroid glands.
4 tiny glands the size of a grain of rice. They sit on the back of the thyroid.
And they control all the calcium in your body.
They're the thermostat for calcium. And they share a blood supply with the thyroid, so it's very easy to accidentally cut off their blood supply or even remove them.
And if they stop working?
Your blood calcium plummets. Hypocalcemia. And since calcium runs your muscles, things go haywire.
And that's where those weird signs come from.
It starts with tingling around your mouth, then fingertips. If it gets worse, you get tetany, muscle cramps.
What about Chvostek's sign?
That's where you tap the patient's cheek over the facial nerve. If calcium is low, the nerve is hyperexcitable and their face will twitch.
You tap the cheek and their lip jumps.
It's freaky. And Trousseau's is even more dramatic. You put a blood pressure cuff on their arm, inflate it, and the lack of blood flow makes their hand spasm into a claw shape.
A claw.
The wrist and fingers flex. It's called the obstetrician's hand. It's painful and very scary for the patient.
It's like the body is short-circuiting.
It is. That's why we check calcium levels religiously after surgery.
So back to Rohini.
Yeah.
Her case was managed with that hemithyroidectomy. It was likely benign.
Exactly. By removing half, they remove the pressure risk. They definitively ruled out cancer by looking at the whole thing, and they fixed the cosmetic issue.
And what about her life after that? Does she need pills forever?
Not necessarily. Since she has half a thyroid left, there's a good chance that remaining half will just work a bit harder. It hypertrophies and does the work of 2.
The body is amazing.
It really is. She might be completely medication-free.
So bringing this all back, what does this deep dive mean for someone listening, maybe someone touching their neck right now?
It means a lump is rarely just a lump. It's a whole story. But the big takeaway is that the really scary stuff often gives clues that aren't the lump itself. It's the voice, the swallow, the lymph nodes.
And that our technology has limits. I think that's what stuck with me. That sometimes there is no substitute for just taking the thing out and looking at it.
Absolutely. Medicine is still an art of observation.
Here's a thought to leave you with. We talked about how these nodules grow silently for years. Rohini had hers for 3 years. Just makes you wonder, how much of our health is defined not by what we feel, but by what our body is quietly tolerating right up until the moment it can't anymore?
That's a profound question. The body is the master of compensation until that swallow test reveals the truth.
Exactly. Thanks for joining us on this deep dive into the detective work of the thyroid. We'll catch you in the next one.
Stay